Hi everybody, my name is Stacy Simpson. I am nurse faculty at Gaston College and I'm a doctoral student at Gardner-Webb University. Today we are going to be playing a virtual board game called Don't Kill My Kidneys, where we are going to be discussing advanced fluid and electrolyte imbalance and how that relates to kidney failure. So without further ado, we will get started with the objectives and then I'll show you how to play the game. Our learning objectives today are going to be to discuss the functions of a healthy kidney, compare and contrast chronic and acute kidney failure, apply knowledge of metabolic acidosis as it relates to kidney failure, and to accurately measure intake and output. How to play. Each student has 2 kidneys with a total of 2 lives. Makes sense, right? You have 2 kidneys, they each have 1 life each. For each minigame question answered correctly on the first try, your kidney gains a life. However, for each minigame question answered incorrectly, your kidney loses a life. Once you complete a minigame, you may move on to the next. There are 6 minigames embedded in this game. If your kidney life reaches 0, then you've killed your kidneys. And obviously, hence the name, Don't Kill My Kidneys. The object of the game is to keep your kidneys alive. Got it? All right, go kidneys! One of the main functions of our kidneys is blood pressure regulation. Now we've talked about how kidneys secrete renin, which then play a role in the renin-angiotensin-aldosterone cascade to help regulate blood pressure. This is in response to decreased blood pressure. So that decreased blood pressure is going to send a signal to your kidneys saying, hey, we need some help here. Kidneys are going to release renin, which is going to trigger that cascade, and all of that causes vasoconstriction, thus increasing the blood pressure. Another major function of our kidneys is waste removal. So you eat and drink, your body takes in the nutrients that it needs, that unused matter becomes waste, the kidneys filter out waste and water from your blood, and then the waste exits the kidneys in the form of urine. Your urine is essentially filtered blood when your kidneys are working properly. Another major function of our kidneys is red blood cell production. Production of erythrocytes, or red blood cells, is called erythropoiesis. And this production is regulated by a hormone erythropoietin, which is secreted by our kidneys. And as you can see by the chart, if there is any anemia or low red blood cell count, that's going to stimulate the kidney to increase the secretion of EPO, or erythropoietin, to help regulate and maintain homeostasis for that red blood cell concentration. The reason we've gone over a brief review of a healthy kidney is so we can better understand what happens when our kidney is not healthy. The signs and symptoms of a diseased kidney directly correlate with the functions of the kidney if it's not able to do their job. So weight gain, if it's not able to excrete the fluid it needs to, hypertension due to that renin secretion that plays a role in blood pressure, decreased urine output, which could also lead to the weight gain and increase in fluid volume, increase in toxins in the blood, which we're going to tie those into lab values later on in this module, and a decrease in red blood cell production due to that erythropoietin process. All right, are you ready for our first mini game? The question is, which of the following statements is true about the functions of the kidneys? A, kidneys regulate blood pressure by erythropoietin. B, kidneys filter waste products by stimulation of red blood cells. C, kidneys secrete renin in response to low blood pressure, or D, kidneys secrete renin in response to high blood pressure. I'll give you just a few seconds. And the correct answer is C, kidneys secrete renin in response to low blood pressure. How are your kidneys doing? Did they gain a life or lose a life? Still confused? That's okay. Let's talk this out. Which of the following statements is true about the functions of the kidney? So we are looking for a true, correct statement here. A, kidneys regulate blood pressure by erythropoietin. That is false. They regulate blood pressure by secreting renin. Erythropoietin is the production of red blood cells. B, kidneys filter waste products by stimulating red blood cell production. That is also false. They do this through the glomerulus and filter out the blood and the waste products and excrete it in the urine. C is the correct answer. And D, kidneys secrete renin in response to high blood pressure. That is false. Kidneys, in fact, would reduce renin in response to high blood pressure to help bring that blood pressure down rather than secreting more renin, which would cause vasoconstriction and bring that blood pressure up even higher. When kidneys aren't functioning properly or when kidneys are in failure, this is going to result in a fluid volume excess, which is going to result in an increased blood pressure due to all the excess fluid volume and the inability of the kidneys to regulate that blood pressure, weight gain, again due to all the excess fluid volume, edema, and electrolyte imbalance. So particularly patients with kidney failure are going to have an increased potassium, and we want to restrict their sodium levels because, as you can recall, sodium actually increases the fluid volume even more. So that's going to create an even further fluid volume excess. Some of the nursing interventions for this fluid volume excess would be: 1, monitor daily weight at the same time every day. In the absence of the pillows and blankets, if those are on the bed, make sure it's being accurately measured. Fluid restrictions, again, fluid volume excess, so they might be on dietary considerations as far as low potassium diet, but the fluid restrictions as well. Administer diuretics and antihypertensives. The diuretics is going to help pull some of that fluid off, and antihypertensives is going to kind of serve two purposes: to help reduce the blood pressure due to the fluid volume excess, and it can also help reduce the blood pressure due to the kidney's inability to regulate it. And monitoring the lab values. So that could be anywhere from electrolytes as you're referring to fluid balance, but that could also refer to some of the lab values that are associated with kidney failure or kidney disease in general, which we're going to talk about in the next module. All right, are you guys ready for the next mini game? Some of your kidneys might only be sitting on one life. Here we go. The nurse is caring for a patient with chronic kidney failure. The following is the patient's total intake and output for the day: 12 ounces of water, 6 ounces of coffee, and 60 ounces of fluid and solute removal during dialysis. How many milliliters of fluid is the patient positive or negative for the day? So I'm looking for the total day's intake and output. A, positive 540 milliliters. B, negative 1800 milliliters. C, negative 1260 milliliters. Or D, positive 1260 milliliters. I'll give you a few seconds to work out the math. The correct answer is C, negative 1260 milliliters. If you're still a little curious about how I made it to that answer, go ahead and click that rationale and I'll explain it. Okay, so the question was to figure out the total intake and output for that day. Is it positive, negative? What's going on? So you guys know I'm a visual person, so we've got it all written out for you here. I started with the 12 ounces of water. That's positive. That's what that patient took in. They also had 6 ounces of coffee. Also positive. And then they had 60 ounces of that fluid pulled off during dialysis, so that's negative, right? These are also in ounces. We need milliliters. Our answer was looking for milliliters, so we're going to have to convert. There's 30 milliliters in 1 ounce. So what I've done is I did 12 plus 6 equals 18, and then I multiplied that by 30 to give me the 540 positive milliliters. Then I took the 60 that was pulled off during dialysis, multiplied that by 30, which gave me 1800, which is negative. So then I took that 540 and I subtracted 1800, which gave me a negative 1260 milliliters for the day. So their total intake and output gave a negative 1260. So you might be thinking, Well, basic fluid and electrolytes, we want that patient to be taking in approximately what they're excreting. But you've got to think this is a kidney failure patient. They're full of fluid. They're in fluid volume excess. So we want that to be a negative number. That shows us that the dialysis, the diuretics, the fluid restrictions, all of that stuff has been effective because they're excreting more than what they're taking in. And that excretion obviously might not be through urination. It was through dialysis, but they're still letting more fluid go than what they're taking in, which is what we want. Here's a list of some of the most common labs that you will see be abnormal in someone that has kidney dysfunction. The first one being the BUN, or the blood urea nitrogen. Urea is a byproduct of protein breakdown, and that builds up in the blood because the kidneys are unable to excrete this. Normal values for that are between 7 and 18, and this is always going to be increased in someone with renal dysfunction because those kidneys can't excrete this waste product, this byproduct of protein. The next one is creatinine. This is also a waste product, and it's typically between 0.6 and 0.7 to about 1.3. This is also going to be increased with renal disease or insufficiency because, again, it's a waste product and the kidney's not functioning, can't filter out that waste. The glomerular filtration rate needs to be greater than 90 for us to believe that it's filtering properly. So anything less than 90, we're concerned about those kidneys' ability to filter. Also, the total protein should be about 6 to 8. This is increased, again, in someone with poor renal function because they're unable to break that down and excrete that in their urine. So therefore, if it's already increased, you would probably want to decrease the amount of protein in this patient's diet. When looking at an ABG for a patient that has impaired kidney function, you are going to see metabolic acidosis, meaning there's going to be a decreased pH and a decreased bicarbonate. And this is due to the impaired ammonia excretion, the decreased tubular reabsorption of bicarbonate, so that lessens how much they actually have, and an insufficient production of bicarbonate, also even further lessening how much bicarbonate they have. And that's what gives you the metabolic acidosis in someone with kidney dysfunction. And our mini game is going to go even further in depth about how to read and interpret these ABGs. All right, here comes mini game 3. Which of the following blood gases is indicative of metabolic acidosis? A pH of 7.45, bicarb of 27, CO2 of 35. B, pH of 7.34, bicarb of 27, CO2 of 55. C, a pH of 7.42, bicarb of 24, CO2 of 37. Or D, a pH of 7.33, bicarb of 20, and CO2 of 35. I'll give you just a few seconds to work that one out. The correct answer is D, a pH of 7.33, a bicarb of 20, and a CO2 of 35. And we'll get into the rationale next if you happen to miss that one. How are your kidneys doing? Are anybody's kidneys dead yet? Okay, so for this one, we were interpreting the results of the arterial blood gas. Now we know that kidney failure causes metabolic acidosis, but you also need to be able to read and interpret that ABG. I told you they weren't going away. So I've got it written out here of how we do these. So we have 7.35 to 7.45 is the normal blood pH. Anything less than 7.35 is acidosis. Greater than 7.45 is alkalosis. So we're already acidosis. We're looking for something with a pH of less than 7.35. The bicarb normal level is 22 to 26, and the CO2 normal level is 35 to 45. Okay? And according to Rome, see, there we go. Can you see that? Okay. Respiratory, meaning the CO2, would have to be opposite of the pH. So if the CO2 was high, the pH would have to be low to indicate a respiratory problem. Metabolic is equal. So if the bicarb was low, the pH would also have to be low to indicate a metabolic problem, again in relation to pH. So let's look at our correct answer choice here, where our pH was 7.33. We know that that's acidotic. It's less than 7.35. And our bicarb is 20, so that's also low because normal bicarb is 22 to 26. So that fits our Rome, metabolic equal, the pH is low and so is the bicarb. And in this case, the CO2 is normal, so that doesn't even really play an effect just yet. So this would give you metabolic acidosis. Make sense? All right. The onset phase of acute kidney injury begins with the contributing event, whatever caused it. So the picture there to the right kind of gives a whole bunch of different causes for this, but let's just say excessive fluid loss, or excessive blood or fluid loss, so we're not perfusing to our kidneys. Maybe that's what caused. So we've got the onset due to that hemorrhage. Next, we get the oliguric phase, which is associated with less than adequate urinary volumes. You might still have some, but less than adequate. And just to remind you, we want at least 30 cc's an hour to let us know that the kidneys are functioning properly. Then we have the diuretic phase. That begins as the nephrons begin to recover. So let's say that patient was hemorrhaging, but they got to the hospital and they got a blood transfusion and they stopped the bleed. Now the diuretic phase begins where we have an increased water content in the urine and excretion of waste continues to be impaired. Then we have the recovery phase, and this may take several months depending on the injury or longer, while the GFR, the glomerular filtration rate, and the tubular function are restored. And then you can check these by looking at those renal labs that we talked about in the previous module. Chronic kidney disease, unlike an acute kidney injury, is a result of typically more internal conditions or systemic diseases such as diabetes mellitus or lupus, something that's chronic, that's continuously happening, not like the hemorrhage example we gave that you can resolve that external factor and then resolve the injury. This is a more chronic case. And chronic kidney disease is measured in stages, looking at that GFR or that glomerular filtration rate. Again, we want that to be greater than 90, so that would be stage 1, where you only have slight kidney damage. And then, as you can see from the slide, that stage 2, 3, 4, and 5 gradually have a GFR rate of less and less and less. And that's how we stage how severe that chronic kidney disease may be. Kidney failure can be from chronic or an acute kidney injury, or formerly known as acute kidney failure. You might see that in some resources. But that kidney failure is when it's progressed to the point that those nephrons in the kidneys can't do their job. So fluid balance, blood pressure regulation, acid-base balance, all of those things we talked about in the beginning of this module. This can be a result of untreated acute kidney injury or the progression of chronic kidney disease to a stage 5. At this point, when we're in full-blown kidney failure, dialysis or a kidney transplant is what's going to be needed to sustain life. All right, it's time for mini game number 4. I hope your kidneys still have some lives left and maybe even gained a few. The nurse educator is giving a presentation to a group of nurses on kidney failure. Which of the following statements made by a nurse about acute kidney injury, or AKI, indicates a need for further teaching? A. The patient will need to plan their life around future dialysis appointments. B. Drugs, toxins, dehydration, and inflammatory disease may have contributed to the kidney injury. C. The oliguric phase is the second phase of AKI, and the patient will show signs of excessive urination. Or D. There are 4 phases of AKI: onset, oliguric, diuretic, and recovery. I'll give you just a few seconds. The correct answer is A. The patient will need to plan their life around future dialysis appointments. That statement is incorrect and indicates a need for further teaching. If you need further explanation, you can go ahead and click that rationale. So this question is asking, the nurse educator is giving a presentation to a group of nurses on kidney failure. Which of the following statements made by the nurse about acute kidney injury indicates a need for further teaching? So first of all, it's important to note that this question is looking for an answer that is incorrect, indicating a need for further teaching. So A, the patient will need to plan their life around future dialysis appointments. This is incorrect. This is an acute kidney injury at this point. Hopefully, we can just reverse that. We would want to treat it, push fluids, do things before it progressed to kidney failure or chronic kidney failure stage 5. So this is an incorrect statement. Well, let's just look at the other ones just to be sure. B, drugs, toxins, dehydration, and inflammatory disease may have contributed to the kidney injury. That's true. All of those could have caused an acute kidney injury. C, the oliguric phase is the second phase of AKI, and the patient will show signs of excessive urination. So this answer is partially true. And if any one part of the answer is false, the whole answer is false. So the oliguric phase is the second phase of acute kidney injury, but they are not excessively urinating during this phase. They actually are going to show signs of decreased urination during this phase. The diuretic phase, which follows the oliguric phase, is where you're going to see that excessive urination. And D, there are 4 phases of AKI: onset, oliguric, diuretic, and recovery. That is true. So that leaves A as our only incorrect answer, indicating a need for further teaching. All right. Dialysis is a procedure for cleaning and filtering the blood because the kidneys are unable to do so at this time. Maybe they're in stage 5 chronic kidney failure or an acute kidney injury was left untreated. So this is kind of an artificial way of doing what the kidneys would be doing if they were working properly. And the way that we do that is through an atriovenous fistula, where you kind of have one that's on a venous end to bring the blood back and one that's on an arterial end to take the blood away. So we pull all the blood out and run it through the dialysis machine, clean and filter it, and then give all of it back. So we use this AV fistula for access. So this is kind of like that patient's lifeline. We don't want to do anything to mess it up. You can feel it for a palpable thrill to make sure that it's functioning properly, but we do not take blood pressure on this arm. There's no sticks on this arm. Again, this is their lifeline. We want to make sure that it is functioning properly. There are 2 types of dialysis: hemodialysis and peritoneal dialysis. Hemodialysis has some advantages and disadvantages, just like peritoneal does. Some of the advantages for hemodialysis is a rapid removal of the solutes in water. It takes less time. There's no risk for peritonitis as there would be for peritoneal dialysis. And personnel typically perform this procedure in a dialysis center. The drawback to that is that your lifestyle revolves around those appointments. These patients have to go up to 3-4 times a week to go have this done. So you can imagine trying to keep a full-time job or doing anything. You have to revolve your life around these appointments. Some other disadvantages would be that bulge from the fistula or graft is kind of obvious, so that might cause some body image issues. Risk for vascular complications. There are strict fluid and dietary restrictions when you are on hemodialysis. And again, like I said, the lifestyle revolves around those appointments. And home hemodialysis, if you're going to do it there, requires space for that machine and training on how to use it. Peritoneal dialysis also has some advantages in that it is simple to perform. It can facilitate independence because the fact that it is simple to perform allows patients to do this at home, facilitating their independence. There's easier access, no anticoagulation. There's fewer problems with hypotension or disequilibrium as you would have with hemodialysis. There are still dietary and fluid restrictions that go along with being in kidney failure, but they're a bit less rigid in peritoneal dialysis. And so that leaves more flexibility in the lifestyle and activities that these patients can choose to perform. Some disadvantages is that it is more time consuming. Typically these patients hook it up and let it run overnight. There is weight gain from the glucose in the dialysate. Peritonitis is a potential complication because you are injecting a solution directly into the peritoneal cavity and pulling it back out. And it does require training and motivation to continue to do it properly and the way that they need to be doing it to make sure that it's effective. All right, ready for mini game number 5? Which of the following are nursing considerations when preparing a patient for hemodialysis? Select all that apply. A, hold blood pressure medication. B, palpate for a thrill in the fistula, C, administer insulin, or D, ensure the patient that has eaten a large meal. I'll give you just a few minutes. The correct answers are A, hold the blood pressure medication, and B, palpate for a thrill in the fistula. Both of those are correct. If you need further explanation on that, go ahead and click that rationale. So the question was, which of the following are nursing considerations when preparing a patient for hemodialysis? Select all that apply. A, hold the blood pressure medication. B, palpate for a thrill in the fistula. C, administer insulin. Or D, ensure the patient has eaten a large meal. The correct answer here is A and B. We're going to hold the blood pressure medication because the act of dialysis itself will lower the blood pressure. So we don't want to give a blood pressure medication, lower the blood pressure, then have dialysis, lower it even more, and have a hypotensive episode. We also want to palpate for a thrill in the fistula. We want to make sure that that access site is working before we send a patient to dialysis. Administering insulin is not necessary at this time, even if our patient is a diabetic, because they're not going to be eating during dialysis, so we would want to hold that as well. And it's along the same lines, ensuring the patient that has eaten a large meal, we don't want to do that prior to dialysis. The only other thing that you may want to check before dialysis is that daily weight, because that's how you're going to determine how effective dialysis was, and the lab values, especially the glomerular filtration rate, BUN, creatinine, to see how effective the dialysis was. Some of the nursing interventions for someone with kidney failure would be fluid and dietary restrictions. Fluid restrictions, again, that kidney's not able to pull off that fluid. A way that we could do that is to give our patient a variety of small containers, small measurable containers. That way, if they want more than just water that day or something, they can put something in each of those containers to have a variety, but still make sure they don't go over their limit. Dietary restrictions, we want decreased potassium, so trying to avoid foods that have high potassium like bananas, avoiding phosphorus-containing foods such as milk, fish, poultry, those types of foods, and trying to decrease the protein. Because again, even though we want our patients to have, protein's good for us, but a byproduct when that protein is broken down is urea, and that's going to further elevate that blood urea nitrogen. Administering antihypertensives and diuretics. Again, our kidneys aren't able to regulate our blood pressure, so giving an antihypertensive to keep that in check and diuretics to further pull some of that excess fluid off. Daily weights to see if our diuretics and our dialysis have been effective. Monitoring labs and electrolytes, the ones that we talked about, BUN, creatinine, potassium, phosphorus, glomerular filtration rate. Monitoring strict intake and output, we want to know if we're able to pull some of that fluid off or if we're gaining fluid. Medications such as sodium polycisterine sulfonate, which otherwise known as K-exolate, to help pull some of that potassium out and excrete it in their stool to decrease that potassium. They also give epotin alpha, which helps further to increase that red blood cell production because our kidneys are unable to do that. And comfort from pruritus. In end-stage kidney failure, all of those toxins have to come out somewhere. And sometimes that comes out on their skin, which can cause itching and discomfort that way. So we can provide lotions and things like that to help topically with that pruritus. For our last mini game, I'm going to give you guys a chance to redeem your kidneys if they have died during this game. Rather than it being a question, now that you've completed all of the modules, I want you guys to create a concept map and just word dump everything you've learned about fluid and electrolytes as it relates to chronic and acute kidney failure. I'm going to make one too, and then in our last module in 9, when we do a review, I'm going to show you what's on mine, and you can kind of compare and contrast with what is on your concept map. But I want you to really try without using your notes, without going back through any of this, so that way you can identify the areas that you're weak in. So if you wrote down all those labs, no problem, but you didn't cover any of what dialysis was, then you know that you need to go back and kind of review dialysis, okay? So that is mini game number 6. You guys go ahead and finish that up, and then when you're ready, go ahead and click the module 9, and I'm going to show you guys my concept map. Okay, so mini game 6 was to create your own concept map. So I'm going to show you my concept map that I quickly just ran through everything that was discussed in the modules. Obviously there's more detail in the modules, but this kind of goes through what we've talked about. So I'll show you what mine looks like. Make sure you guys can see that. So I've got the nursing interventions in the middle because a lot of those correlate with both chronic kidney failure and acute kidney injury. So things like daily weights, INO, the different medications, lab values, the diets, I've got all those listed in the middle. For chronic kidney disease, I've got the stages listed and the fact that if this does progress to a stage 5, that's when we would have kidney transplant or dialysis. And then the 2 different dialysis, we've got hemodialysis and peritoneal dialysis. Acute kidney injury, I put treat the cause. We want to hopefully treat the cause before it progresses to kidney failure. And we've got those 4 phases, the onset, the oliguric, diuretic, and recovery phase there. I'll let you kind of see the bottom. Okay, so I don't have a whole lot of details. Obviously in the module there's more details than what is on my concept map, but hopefully that's helped serve as kind of a guide for you guys of how much you retained and maybe what you need to go back and review the module again, or go back to your book and reference that reading. I would also like you guys to keep a little log of how many lives your kidney either has or does not have. And you can give yourself an extra life if you feel like your concept map was pretty comprehensive and had a lot of what mine did on there, even more than mine. I want you to write down your kidney lives and bring those to the Collaborate that we're going to do as a follow-up to this game, because we're going to use that as kind of a little activity that we're going to do during our Blackboard Collaborate. So I hope you guys enjoyed it. See you at the Collaborate.